Hello, everyone. I hope that you all are doing fine. And yeah, so I'm also good. In previous few days, I was not very well. That's the reason I did not made any video or recorded anything. Okay, so now we need to do this very important topic here, which is the diabetes. You know that the diabetes is very common condition. Even it is in Australia or India or any other countries as well. It's at very growing level, and most of the patient does have diabetes, and so we need to study this topic very thoroughly, and according to exam point of view as well, you will get few scenarios in which your patient would be diabetic, so you should know what and how to handle them. Okay, so, in dental practice, first aid management of hypoglycemia, we will read all these medical emergencies in the later chapter, in the later topic, because they are also important. If any medical emergency happens in your clinic, you should be eligible or you should know how to treat that patient. Okay, so for patients with diabetes, you need to take a thorough medical history and you need to determine if their diabetes is well controlled and stable. Consult the patient's medical practitioner if needed. Okay, so you need to ask the patient thorough medical history. You need to make sure that their diabetes level is controlled and stable. If you are not sure, then you can also consult their GP. Glycated hemoglobin, which is the HbA1c level, above the patient's target, it is an indicator of poor glycemic control. Glycemic targets are individualized. A common glycated hemoglobin target is 53 mmol per mole, which is the 7% or less. Okay, so you need to remember this value, up to which value the patient's glucose control is normal and which is abnormal. Poorly controlled diabetes is associated with post-procedural complications. So, if the patient has poorly controlled diabetes, what complication can occur? In chair, the very major complication that could occur if the patient's diabetic is not under control is the hypoglycemia. But these patients are also more prone to get the post procedural complications, which would be infection. There are high chances of infection in these particular patients, and their wound healing would be poor. Although the risk of post-operative infections can be higher in patients with poorly controlled diabetes, still antibiotic prophylaxis before starting any treatment is not recommended for them. Like, although we know that the poorly controlled diabetic patient would have these complications, they have more chances of these complications to happen, but still we should not prescribe them antibiotic. So in Australia, they are very, conscious, not n- like when in clinic, they are a bit different, but according to these books or according to these guidelines, they are very particular about the antibiotics. So you should be very cautious when you are prescribing your patient these antibiotics. So always try to limit the use. Patients with poorly controlled diabetes, they are at increased risk of periodontal disease. Okay, so diabetic patient has higher risk of periodontal disease. Why? Because diabetes causes inflammation of the organs, right? And the gum inflammation is also one of the symptoms. And what happens is when in our blood the level of sugar is higher, then more number of bacteria can survive on that, can thrive on that, and that would make our gum to go unhealthy. And these diabetic patient does have very poor periodontal condition, and it is also very important for you to understand the relation between periodontal and the diabetes, because for the if their like gum issue, if they are having a lot of bacteria in their gum or they are having any gum disease, it can also manipulate their diabetic level. So they do have interrelated relationship. Diabetes may be associated with sialidosis, which can cause impaired salivary gland function, which means that these patients would have dry mouth. Okay, then for all patients with diabetes, you need to provide regular dental care, which is the 6-month dental review, including instructions in oral hygiene and denture maintenance. If the patient does not have any denture, then you need to give them the instructions according to the oral hygiene, which are 2 times brushing, 1 time flossing, and 6 monthly regular dental visit. And for the denture maintenance, you need to advise that you need to take your denture out during the night time, clean it with the warm water with the mild soap and soft toothbrush, and keep it in a dry medium. Consider the possibility of undiagnosed diabetes in patients with sudden onset or progression of periodontal disease. If any patient has come to you, okay, and he has a uncontrolled or very progressive periodontal disease, even though you have done the treatment, but still his gums are not responding, but he has, then you can suspect that this patient might have diabetic. Okay, so poor response to periodontal treatment, even there is a progression of periodontal disease, or you have done the scaling and cleaning, and still his gums are not healthy, getting healthy, then you can also suspect. Or there is poor wound healing, or recurrent or persistent bacterial or fungal oral infections. For example, the candidiasis. It is also linked with the diabetes. So when you read in the candidiasis topic, they have mentioned the poorly controlled diabetes is one of the reason of the patient to happen a candidiasis in their mouth. Then dental procedures in patients with diabetes. What dental procedures you can do and how? Use clinical judgment to decide whether a patient with diabetes can be safely treated with outpatient dental treatment or if they require dental treatment in hospital. Okay, you need to use your clinical judgment for this. Most patients with diabetes have a routine of medication, their diet, activities, and blood glucose monitoring that maintains blood glucose concentration within the safe limit. So it means you need to ask your patient about their meals, about their medication, and about how are they managing it. It means how often they are going to their GP or their doctor to get their blood sugar test done. Provided this routine is not interrupted, then if the patient is following all these things, then you can treat the patient in the outpatient setting, and there is no problem with that. And in box 22 we will read here what certain precautions you may need to take for these patients. Okay. Then optimal glycemic control periprocedurally improves outcomes in patients with diabetes. If possible, postpone elective dental procedures until glycemic control is optimized. So here they have said that although it is required, if the patient's glucose level is good, then the response would be far better. Okay, so you can postpone the elective dental procedure, which means scaling and cleaning. You can postpone it until their glycemic control is optimized. However, do not delay treatment of acute or infective dental conditions. If unsure whether dental treatment can safely proceed, then consult their patient's medical practitioner. Okay, so here they have mentioned that you can postpone their elective dental procedures, which are like the scaling and cleaning, 6 monthly visits. You can postpone that thing. But if there is an acute infection or if the patient is in pain, then you need to talk to their GP to find out what safe treatment you can do for them. SGL2 inhibitors may need to be stopped temporarily before a dental procedure. So some patients of diabetes, they might be taking this class of drug, which is the SGL2 inhibitors, and it is very important that you need to temporarily stop this medication because it can lead to more complications. We will read in this paragraph which what they try to mention here. If pre-procedural fasting is required, example for the procedures like general anesthesia or intravenous sedation for these diabetic patient, then the procedure should be must be supervised by the medical practitioner. So you won't be doing all these procedures which would require GA or IV sedation because it is beyond the domain of uh, a normal general dentist. You may need to do certain other procedures and other certificates to do that. Okay, so dental procedures in patients taking SGL2 inhibitors. So if these patients are taking these drugs, which are dapagliflozin or all the drugs which have the flozine part, have been associated with the development of euglycemic diabetic ketoacidosis. So there is high chance of these patients to develop the diabetic ketoacidosis. In patients with type 1 or type 2 diabetes, the risk of diabetic ketoacidosis is increased in patients taking SGL2 inhibitors who have been fasting for who have been fasting or have very restricted dietary intake. So in which patient the risk is more? If the patient is fasting or have their restricted diet, or they have undergone a surgical procedure, or they are dehydrated, or they have any acute infection. In these scenarios, if the patient is taking this drug to manage their diabetes, then there is very high chance of them to get going under diabetic ketoacidosis. For prolonged dental procedures or procedures in which fasting or dehydration is likely either before or after the procedure, consider stopping SGL2 inhibitors pre-procedure. So even if you need to do, you need to stop this medication or you need to alter anything, you cannot do by yourself. You need to do the consultation with their medical practitioner, which is their GP. Alerts highlighting the peri-procedurally risk of diabetic ketoacidosis in patients taking SGL2 have been issued by the Australian Dental Society, and this is a link that you can go through and read in more detail. Okay, so the summary of this is that these patients have higher risk of getting into this very complicated condition, which is the ketoacidosis. So, and in some scenario, you may need to stop their dosing, but you are not the only person who would decide for them. You need to take the advice from their GP about that. Okay, so this is box 22, which states how you can manage a patient with stable diabetes undergoing a dental procedure in an outpatient setting. So what is the foremost criteria? His diabetic should be stable. You cannot treat the unstable diabetic patient. Okay, even if there is any acute or infectious condition, then you need to take advice from their medical practitioner and weigh the benefits and the harms. So before the procedure, what you need to do is you need to determine their usual routine, which is you need to ask them, have they taken the meal? Did they took their medication on time, and when was the last blood test done, and what was the reading, and did they have they undergone any like vigorous activity or strenuous exercises or anything that can destabilize their diabetic control. Then you also need to determine whether any type of activity destabilizes the patients, like what can trigger their diabetic glucose control. Then for patient taking SGLT2 inhibitors, there are certain management that we may need to consider stopping that, so you need to talk to their GP about that. Determine the extent and the type of dental treatment required. Ask patient to bring their glucose monitor on the day of the procedure if they use one. Then scheduling the procedure, schedule the procedure for the morning. So if there is any potential sequelae, it should be resolved during the daytime. Consider the patient's usual meal time and medication regime. Aim to minimize interruptions. Do not interrupt their meal and medication timing, because they do have certain, like they do regularly they do the breakfast around 8 a.m. So you should make the appointment around 9 or something. That would not interrupt their routine, and avoid extensive treatments and longer appointments. On the day of the procedure, what you need to do is you need to check the patient, have they taken their meal, their medication, and how well they are feeling. Okay, so if the patient has missed a meal, then what you can do is you can ask them to eat and wait for 30 minutes and then otherwise reschedule the appointment. Do not give patient glucose or any sweetened drink just in case. This is ineffective and can destabilize their diabetic management. If a patient feels ill during the procedure, then you need to stop the treatment, assess their blood glucose concentration if a blood glucose monitor is available. If unsure of the cause of their symptom, then you need to call 000. Do not allow the patient to leave your care if they are unwell or confused. And after the procedure, you need to advise them to take their usual meal, like usual calorie intake, activity level, and their medication, even if their mouth is sore, because we cannot destabilize their glucose monitoring, right? Then provide dietary advice on preparation of like, because they would be numb and they would be in pain, so advise them to eat the soft food, but they maintain your caloric intake, which is important if they are likely to have difficulty eating. This topic is over here, but it is very 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 important topic, and diabetes is very common in Australia, so you should be more very very thorough with this topic. Okay, and then HIV infection. Antiretroviral drugs interact with many commonly prescribed drugs. So these medications, if the patient has HIV and they are taking these antiretroviral drugs, so they have many interactions with other drugs. So before prescribing any drug to these patients, you should consult their HIV expert. Unusual and rare adverse reactions, example perioral paresthesia, can occur with antiretroviral drugs. With currently available antiretroviral therapy, many patients with HIV are well managed and stable. However, patients with HIV infection, they are more particularly the smokers, they are increased risk of oral diseases such as candidiasis, which is the opportunistic infection, then periodontal disease, necrotizing periodontitis, oral hairy leukoplakia, squamous cell carcinoma, HIV-related salivary gland hyperfunction can occur, and which would increase the risk of candidiasis, because if there is dry mouth and the immunity is low, the chances of candidiasis is very much. Then other oral manifestations of HIV would be recurrent aphthous ulcers, then intramucosal hemorrhages, and hyperpigmentations of the oral mucosa. Some conditions are particularly related to late stage HIV, such as Kaposi sarcomas and oral hairy leukoplakia. Then oral diseases and opportunistic infections in patients with HIV infection should be managed in conjunction with, whenever you are doing any management of their oral disease or any infection, you should do it in conjunction with their HIV expert, and refer to an oral medicine specialist may also be appropriate. So it is better that you refer these patients to the specialists, because their immunity level is very low and they are very prone to get all the infections, and the treatment outcome would also not be very great. So it is a better idea if you would refer them to the oral medicine specialist and they would work in conjunction with the HIV expert. Then immune compromise. Patients with immune compromise, they are at increased risk of infections. The dental management of an immunocompromised patient requires a multidisciplinary approach. Conditions that can cause profound immune compromise include end-stage kidney disease, end-stage liver disease, malnutrition, untreated or end stage HIV infection, and malignancies. Okay, so kidney disease, liver disease, HIV, malignancy, and malnutrition. So these are the conditions in which the patient would be profoundly immunocompromised. Conditions that can be treated with immunosuppressive therapies include like autoimmune and inflammatory conditions such as rheumatoid arthritis, psoriasis, inflammatory bowel disease, systemic lupus erythematosus, or any vasculitis. Sorry about the pronunciation. And then organ transplantation and malignancy. So these patients would be taking the medications which does suppress their immunity, which are the corticosteroids, right? The degree of immune compromise affect treatment decisions and the use of surgical antibiotic prophylaxis. For example, poorly controlled diabetes can compromise the immune system, but still there is no indication for surgical antibiotic prophylaxis. This is what we read before. Like even though the patient has poorly controlled diabetes, still you do not prescribe any antibiotic before starting the dental procedure. Conversely, if the patient is profoundly immunocompromised, for example, if the patient is taking high doses of immunosuppressive therapy, like any of these conditions, then they may require surgical antibiotic prophylaxis. Consult the patient's medical practitioner, specialist, or multidisciplinary team to determine an appropriate treatment plan and the need for surgical antibiotic prophylaxis. Okay, then chronic musculoskeletal disorders. Pain and restricted mobility are common symptoms of musculoskeletal disorders. Chronic musculoskeletal disorder. So the musculoskeletal disorders means the muscles, joints, bones, spine, their problem, right? So if the patient has any of these symptoms or any of these diseases, what you need to do is patient would be in pain and restricted mobility due to their musculoskeletal disorder. They may find extended dental treatment uncomfortable because it is very hard for them, because their muscles and bones does not they are painful, so it is very uncomfortable for them if the treatment is long. Modify the treatment to minimize the time spent in the dental chair, and also consider changing the chair configuration, or you can also give them the filler pillow to support their neck, hips, or knees. Patients with chronic musculoskeletal disorders may be prescribed immunomodulatory drugs which can cause immunosuppressions. So, if corticosteroids are used, we have read on page number 163 what we need to do, like what precautions we may need to do, what can happen if the patient is taking corticosteroid, and how we need to change their treatment plan according to the duration and according to the invasiveness of the treatment. Some patients with chronic musculoskeletal disorders take large doses of over the counter or prescription analgesics, which is opiates, because they would always complain, my knees are paining, my muscles are paining, and my joints are paining. So they would just so used to take these over the counter painkiller, and some people would also be taking the opiates. And for the opiates, there are very level of harmful effects, such as that they can lead to dry mouth, and dry mouth would consequently leads to dental caries and gum issues, particularly if taken with other drugs that can cause dry mouth. Consult the patient's medical practitioner if pain management is required for dental indication. If you need to give them any painkiller because they would already be taking over the counter painkillers, then you need to consider talking to their GP or the medical practitioner to find out what pain management you can do for them. Patients with chronic musculoskeletal disorders may have prosthetic joints, and this is not an specific indication for surgical antibiotic prophylaxis before dental procedure. Then, neurological conditions. What can happen from the brain is the stroke or epilepsy and trigeminal neuralgia, and we will start this topic tomorrow, and hopefully I will try to complete all these topics as soon as I can, because I know this is TG is really lingering on. And yeah, so it would be a good idea if we would you know stop, and we would just like quickly complete this topic, this book, because that would help you in your revision. Okay, thank you so much guys for watching, and please do like, share and subscribe my channel. Thank you.